Fatigue tends to be overlooked in the clinical setting, probably because assessing fatigue is both time-consuming and frustrating. We tend to think of fatigue as an hard-to-treat symptom.
I think what we really need in the future, and also where research has to go for, is looking for biomarkers. I think we really need biomarkers telling us, well, this is a patient having fatigue, yes or no.
We need to think about those sleep disorders when a patient complains about their sleep or complains of being fatigued. We need to screen for that, and it's quite easy with questionnaire and with a recording.
I don't think that there is one fatigue profile. There are different profiles. And I think as long as we do not understand the different profiles of fatigue, we also cannot offer the appropriate treatment to the certain profile that a patient might have. Hi, I'm Iris-Katharina Penner. I'm a cognitive neuroscientist and a clinical neuropsychologist. I'm the head of neuropsychology at the University Hospital in Bern, Switzerland.
Hi, my name is Anne-Laure Dubessy and I'm a neurologist based in Paris in La Pitié-Salpêtrière, and I have a special interest in multiple sclerosis and sleep disorders.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. In the MS research world, we spend a lot of time talking about disease mechanisms and how understanding these better will lead to new and improved treatments. However, having listened to the overwhelming feedback of people living with MS around the world, recently there's been an additional emphasis placed on research into symptom management. And when asked about the symptom that has the greatest impact on their quality of life, the majority of people living with MS will respond with fatigue. My guests in this episode, Iris and Anne-Laure, have studied this topic extensively, and together we will be discussing the current understanding of the causes of fatigue in people living with MS, and what strategies may be employed now and in the future to help manage it. Iris, Anne-Laure, thanks for joining me.
Hi, Brett. Thank you for inviting us to participate in this podcast. This is exciting.
Yes, likewise.
So before we get too far into discussing the studies and the science of what's going on, I'd love to hear from both of you why you think it's important that we research fatigue in MS.
So I think, as you say, no neurologist needs to be reminded that fatigue is a common and debilitating symptom for patients with MS, with a major impact on quality of life, employment status, daily living, etc. But on the other hand, I think Iris-Katharina will agree with that fatigue tends to be overlooked in the clinical setting, probably because assessing fatigue is both time-consuming and frustrating. We tend to think of fatigue as an hard-to-treat symptom, and this creates a bias and it creates a self-fulfilling prophecy, meaning we do not investigate fatigue thoroughly enough, and while doing that, we underdiagnose other contributors to fatigue, such as mood disorder, sleep disorder, etc. And we miss treatment opportunities. So I think we need to have a better focus on this symptom to try to alleviate this symptom for patients, to provide patient-focused treatment.
Yeah, I fully agree. I mean, as a psychologist, I see it probably also a little bit more different because I have the impression that fatigue is in clinical routine often neglected by the neurologists. This is not only because they have not enough time to address it with the patient, but also that there is potentially not a huge interest in assessing fatigue. We all know that the EDSS, for example, is not capturing fatigue, also not capturing the cognitive issues. And therefore, I think here is the problem, so that there is probably nothing hands-on for the doctors, that they can really assess it in a convenient way, but also in a reliable way. And I think that's the issue. But for the patient, of course, you mentioned it, it's a most debilitating symptom. And with these high prevalence rates, up to 95% of patients being affected, I mean, it is really a problem. And therefore, we have to address it. And you have to look for treatment options and so on. Yeah.
So what do we understand about the mechanisms that cause fatigue in people living with MS? And you've already sort of mentioned that there are a number of different things that can contribute, and I want to come to that as well, definitely. But do we have a really good understanding of what some of these underlying factors are that are leading to this overwhelming fatigue that people living with MS experience?
Well, so I'm not sure we can resume that in 20 minutes, but because it's a very, very large problem. And I think there is a lot of contributor of fatigue among patients living with MS. And I'm really no specialist of physiopathological mechanism of pure MS-related fatigue, and I think it remains mysterious for most person and most researchers. There is a lot of putative explanation, including damage on reward pathway or cortical thalamic and striatocortical loop, and the neurotransmitter imbalance. But I think this is very putative, and it does not. It can't be addressed through either pharmaceutical or daily intervention for the patient. And I think on the clinical side, we should focus on what can be treated and what can contribute to fatigue and that can be treated, such as sleep disorder, mood disorder associated with MS. And of course, and I think Iris will be more appropriate to talk about that, cognitive behavioral therapy and symptom management.
Yeah, absolutely. But maybe to go back one step, because what you now mentioned is probably also something that we have to keep in mind, that we have different kinds of fatigue. So we have the secondary fatigue, that is what you mentioned by, it can be not supported, but it can be worsened by medication, or it can be worsened by sleep problems, for example. But this is potentially not that what we are interested in. We are more interested in this, what we call primary fatigue. And there is the largest problem, because we don't know the pathophysiological mechanisms. And there are so many studies looking for variations in the CNS and the peripheral nervous system, immune system, endocrine system. But finally, we do not understand the interplay between all these changes. And in my view, there have been some nice hypothetical models published by different researchers, showing that the inflammation, so the inflammatory process is, I would say we agree on that, is the driver for fatigue, not only in multiple sclerosis, but also in other diseases. Might it be Parkinson's disease or ALS, or also in lupus patients, rheumatoid arthritis. This is not unique for multiple sclerosis, but this inflammatory process, for me at least, is the start of the fatigue. But then in multiple sclerosis, I think we have this neurodegenerative aspect that comes in from the beginning on, is there, but comes in and increases as the disease develops. And then I think this is the point where we say, well, this is probably the answer why fatigue is a trait factor and it's not a state issue. So that meaning that the patient will suffer from fatigue the rest of his life. I have never seen an MS patient with an on-off fatigue. So fatigue is something that is a trait aspect that can vary in intensity. But honestly, I've never seen someone coming in and say, well, I'm so fatigued, and then coming back 2 years later, oh, my fatigue is gone. And therefore, I think this is something that we do not understand at the moment. So what is finally hen and egg, and how is the interplay between inflammation, neurodegeneration?
And obviously that primary fatigue is very complicated. Obviously, we still don't know a lot about what's causing it. And obviously, if we don't fully understand that, finding ways to manage it is going to be difficult. I think one of the interesting things that has been discovered lately is around those secondary causes, because while there is always going to still be an underlying fatigue by MS itself, these are things that can be treated, and sleep disorders are a really good example of one that has come up. Anne-Laure, I know you've talked quite a lot about this. This is obviously an area of interest for you. I want to sort of break down those secondary causes, and maybe let's start with sleep disorders. What have we learnt about them in people living with MS, and how they can be treated, and the impact that ends up having on fatigue?
So this is a vast topic, and what we know is, like fatigue, sleep disorders are quite prevalent among patients with MS. Of course, there is a lot of bias because it's mostly self-reported studies, and we lack big data objective measure of fatigue. But what we know is that sleep disorders are quite prevalent. When we do self-reported questionnaire, about symptoms related to sleep, a majority of patients experience sleep disorder. Only a minority of them discuss sleep disorder with their neurologist. Because again, I think that neurologists do not care enough about sleep, and it's time consuming to talk about sleep. What we know from small interventional studies, is that when a sleep disorder is diagnosed and properly treated, patients experience an alleviation, or at least a partial alleviation of their fatigue. Of course, every aspect of the fatigue won't be gone, but they do experience a partial alleviation of their fatigue, and this is positively impact on their daily living. If we want to go through what can a patient with MS experience regarding sleep, there is, first of all, the fact that sleep can be disturbed by a lot of symptoms related to MS. We know that patients experience nighttime symptoms. They can have sleep disturbance due to spasticity, bladder control issues, or psychological issue. You can have insomnia, like everyone in the daily, everyone can have insomnia, but insomnia is more prevalent in MS. And it's treatable. It's treatable with cognitive behavioral therapy, for example. And if you alleviate spasticity or nicturia, you will alleviate quality of sleep. You will improve the quality of the next day. And regarding other sleep disorder, we can spend hours talking about that and inflect that to you. But we need to keep in mind that most sleep disorders are more frequent among patients with MS. We do not really understand why, but it's probably due to lesion in sleep centers in cervical spinal cord. So restless leg syndrome, sleep apnea tends to be more prevalent, and we need to diagnose them. We need to think about those sleep disorders when a patient complains about their sleep or complains of being fatigued. We need to screen for that, and it's quite easy with questionnaire and with a recording. Finally, I have a particular interest in hypersomnia, and hypersomnia can be, we all know that narcolepsy is quite debilitating. We know the typical narcolepsy phenotype, but we tend to overlook the possibility of central hypersomnia that can manifest through sleepiness. And we need to screen our patient for daytime sleepiness. A patient experiencing sleepiness won't come saying, I feel sleepiness. They will say, I'm fatigued. And it's the neurologist that needs to screen for sleepiness, to ask proper questions, because sleepiness is a major red flag for sleep disorder. And if you have sleepiness, you need to refer the patient for sleep evaluation. And then, in this particular case, if you identify a proper central hypersomnia, it can lead to a specific prescription of a wake-promoting drug. But it's only for a minority of patients. But in this case, wake-promoting agents, which have been quite old studies with wake-promoting agents prescribed for fatigue have been quite disappointed. But for some patients, it can really alleviate their symptoms if they suffer from central disorder of hypersomnolence. I'm not sure if it's clear, but...
No, and very interesting. I think something that's been quite new in terms of our understanding of it. I think one of the other ones that we talk about a little bit is depression, and other psychological issues can also be a secondary cause of fatigue. Iris, I don't know if you want to talk a little bit about what we've learned from that and how the treatment of those improves fatigue in people living with MS.
Mm-hmm. Yeah, I mean, just to comment on the sleep disorders, I think that this is probably also something where we can convince the neurologists that they have to look for it. So if they are not interested in fatigue, but then one job might be that they look for the sleep disorders, because we can treat that quite well and then have the decrease in the fatigue symptoms. And that is why we, for example, in Bern, we send all the MS patients complaining about severe fatigue to the sleep clinic, just to get that really recorded and objectified. And concerning depression, I mean, you know as well as I know that the prevalence rates are really high, so up to 50%. It belongs a little bit, or it depends a little bit on the studies that you look at, but 35 to 50% of MS patients have depression. And if you look at the normal population, I think it's about 8%. So you see that's really elevated. And yeah, but what I think is that this kind of depression that we see in multiple sclerosis is not equal to major depression. So it's something different because it's also something coming out of the disease itself. So, and what we from the psychological point of view distinguish is depression at the beginning. So when the diagnosis is set, it's more something that we call reactive depression. You can treat it quite well with antidepressants. And then after some time, it's equalized. And then many years later, you can have patients coming with depression, but mainly induced by the MS itself. And then we see also that it belongs to lesion location, brain atrophy in certain brain regions that finally are responsible then for having this kind of depression. And of course, we have to take this seriously. And also from the psychotherapeutic point of view, we need to treat those kind of symptoms, because we all know that if you have a depression that is untreated over a longer period, then you can really do harm to your brain, because the cells in the hippocampus, for example, they die because of this, something like we call also a chronic stress in the brain due to the depression. And therefore, I think it's also a symptom that we have to take very seriously.
I mean, I think we're getting a really clear idea here that a lot of the bidirectionality of some of these problems is what makes this such a complicated area to address. I just want to pick up on one point that you've both touched on in your answers there, which is around the willingness or the desire to investigate fatigue further in people living with MS. Historically, and we hear this anecdotally from people in the MS community all the time, it would sort of go to an appointment, complain of fatigue being really debilitating, response being, well, of course you've got fatigue, you have MS, this is just part and parcel of the disease. We're understanding now that that's not the case. It's a difficult question to answer, but do you feel like we've made a lot of progress in this area now where they will try and investigate this further to work out the causes? I'm going to guess the answer is maybe, but would love some little thoughts on that.
It's hard to answer, obviously, because I think the more knowledge we gain about causes of fatigue in MS, and secondary fatigue is a good starting point, the more we can know how to interrogate our patient. Because, of course, as we both said, fatigue can be perceived as frustrating, and neurologists, clinicians are problem solvers. So they don't like a problem that can be solved, and they don't like to spend time on something they won't be able to alleviate. So, for example, in my experience, which is very biased, because I think I'm quite good to diagnose underlying sleep disorder, but quite bad at underdiagnosing maybe mood disorder. When we screen with a proper structure interview for a sleep disorder, in most cases, in some cases, it can contribute to have a diagnosis and sometimes a treatment, and sometimes it alleviates fatigue. But also the feedback from patient is very good, because most of the time you can at least explain to the patient the symptoms, the link with sleep disorder, and most of the time there is some minor sleep disturbance. And the mere fact that we take interest into their symptom and we try to understand it and untangle which is part of motor fatigue, which is what is cognitive fatigue, what is due to imbalance of sleep disturbance. All of that helps the patient, at least partially. But neurologists have to have the proper tools to assess and investigate the patient, the proper knowledge, and this is hard to give this expertise to everyone. I'm not sure how to improve that. Probably on a global side, a better understanding of mechanism and what are the strategy, and adopting a more proactive approach, saying to the neurologist, you can do that. Very practical solution, very practical things you can do in the consult. And what should you do, for example, if you suspect a sleep disorder, go to a sleep unit. If you suspect a mood disorder, refer to a psychiatric. Some cognitive behavioral therapy maybe, but for that you need specialist psychologist?
I think we are quite good in excluding other factors that might impact on fatigue. You mentioned sleep disorders, depression, probably also other factors, inactivity or something like this. But I think the problem is that we do not have objective assessment measures for fatigue itself, so for the primary fatigue. And I think in my view, this is really needed, because I see so many patients coming in for early retirement requests, for example. And then I have the problem. Of course, I use my questionnaire. So I have the fatigue questionnaire. I do a neuropsych testing 3 hours, and then I see how the patient is decreasing in performance over time. But nonetheless, the authorities, they say, well, I mean, that's subjective. I mean, the patient is saying, well, I have fatigue, but I'm also tired. I think that's the issue. This is also the problem for the patients. And I think what we really need in the future, and also where research has to go for, is looking for biomarkers. I think we really need biomarkers telling us, well, this is a patient having fatigue, yes or no. And I think here we are at the beginning of the research. And because I think there are some studies on NFL, SNFL, but they are negative. There is a flat line. You don't see any correlation between SNFL and fatigue, and also not with depression and anxiety. You mentioned in the beginning the lesion location, prefrontal cortex, basal ganglia, thalamus. But I mean, in clinical routine, we do not do these kind of analysis. Now we look at the conventional MRI, and then we don't see that there is a connection loss between these areas, for example. And here I think we need research. We need really good biomarkers that can be applied easily in clinical routine. So that would be my wish for the future.
I think it's a really important point, and I want to finish with asking you about what you're most interested in seeing results of in this area, what you're seeing as the most exciting research. But I think we really do need effective measures. We can't expect to have great clinical trials until we have effective ways of measuring it. And I remember a few years ago now, we had a trial that was looking into improving mitochondrial dysfunction in people living with MS. And the fatigue measurement was largely around patient-reported outcomes. How fatigued are you feeling? And while the patients definitely were feeling much better on the treatment, that wasn't being captured in the trial, because while they were still feeling the same level of fatigue, the difference was that their activity levels had gone through the roof. So while they might have been reporting an 8 out of 10 fatigue at the start of the trial, when all they were doing was, getting up and sitting on the couch and then going back to bed, they were an 8 out of 10 on the trial, but they were getting up, vacuuming, going and doing the grocery shopping and doing so much more to get into them to the point where they were fatigued again. And so, yes, having better ways to measure this in clinical trials is critically important. So for the both of you, just briefly, because as you said, we could talk about this topic for a very long time, what are you most excited about hearing about, say, at ECTRIMS 2025 when we all meet in Barcelona? What in this area excites you?
As Iris say, I think as we lack proper measurement and proper biomarker, and there has been a lot of quite disappointing clinical trials, to my knowledge, there is no big clinical news that will arise in the following years. What I find interesting in the very practical aspect of daily living for patients is the emergence of easily accessible device, wearable device that can, I think, help to a certain extent to have a feedback on their activity level. And maybe, I know it's debated because there is subjective fatigue and objective measurement, but I know that objective measurement, at least, for example, in sleep management, but also on physical activity, having objective measurement can help to implement change in the daily routine of the patient, to have feedback on their level of activity and help implement cognitive behavioral therapy in the daily living, not in the rehab center and things like that. So I think we need to appropriate, neurologists need to appropriate these tools, but I think it's an exciting pathway for trying to alleviate symptoms of patients before having a better understanding and scientific understanding on primary fatigue.
Yeah, I fully agree. I think that these digital devices are very helpful also in probably helping to understand the patient. Now I'm feeling probably better. And this is also reflected then that my activity is increasing. So I think that's quite nice also to get this kind of feedback. And I think in terms of therapeutic approaches, I think we have to think out of the box. So we are actually running, for example, a study on meditation and education with the patients. And we see that fatigue levels are decreasing. And I think this kind of approaches are actually not really accepted in the neurological community. But I think that those kind of approaches are helpful for the patients and also in helping to deal with their symptoms in daily life. And on the other hand, still we have to work on this biomarker something so that we get more understanding on the mechanisms. And maybe also something that came into my mind was to probably to gather data from different centers so that we have larger samples and then looking for some kind of profiles. I don't think that there is one fatigue profile. There are different profiles. And I think as long as we do not understand the different profiles of fatigue, we also cannot offer the appropriate treatment to the certain profile that a patient might have. So this is something that I have in mind, but we will see.
Well, look, thank you, Iris and Anne-Laure, for sharing your really valuable insights into this. We've talked a lot about whether people will go and try and investigate fatigue further in people living with MS, understanding that there is things that can be done about it. I think people listening to this podcast will be more encouraged to do that. So thank you for contributing to this.
You're welcome, and thank you for having us in the podcast. Thank you.
And thank you everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MSTranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MSTranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2024-25 ECTRIMS podcast series is supported by educational grants from Alexion, AstraZeneca Rare Disease, and Novartis. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook, and YouTube.